I lead the Military Special Operations Family Collaborative, which is a nonprofit public health initiative for the special operations community. This Health Deep Dive is a follow-on event from our February SOF Team Room, which is a virtual candid legacy conversation that we co-host with the Global SOF Foundation, responding to a need for open, honest, and candid conversation or on topics facing our community. If you joined us for that event, you'll recall that the SOF Team Room hosts health sprints, which provide quick, practical information about health interventions that are being discussed within the special operations community. When you leave the team room, you know you leave and you are not alone, and you leave with helpful information and basic resources. The SOF Team Room starts the conversation, but there's a lot more to learn about each topic that we cover than we can squeeze into a team room. So many sprints take on health interventions that are not yet endorsed as evidence-based care. Those who served or are serving in special operations often have more than one chronic health condition, often tied to persistent high stress and service-related exposures. And this can make finding and accessing effective care hard. This is why we now host these health topic deep dives as an effort to get good health information into the community and explain facts that you need to know. This event is designed to alternate back and forth between two health interventions tonight: Stellate Ganglion block and Psychedelic Medicine. We will cover 4 key areas of health information that you should know and consider on both Stellate Ganglion block and Psychedelic Medicine. After our experts have a chance to cover each main theme, Sergeant Major retired Eric Miares, former SMU operator and U.S. Marine and an MSOF team member, will moderate a question and answer period where you will have the opportunity to unmute and ask the doctors a question on either of these interventions. If you would rather type a question in the chat, Eric can ask the question for you. If these health interventions have been on your mind a while and you already submitted questions, we have them ready and we'll make sure to ask them. As a reminder, please keep your microphone muted. If you aren't speaking, you'll also notice that this session is being recorded. Since these are important topics to many in our community, this deep dive event will be made a resource available following tonight's event. You're welcome to keep your camera off to avoid being recorded. It is up to you. That's enough for me. Now, Lindsay Snook, our operations director, is going to take over and introduce our speakers and the topics at hand. Thank you.
Thank you, Kaylee. I'm honored to introduce tonight's panel of experts who are here to help all of us navigate these treatment options for ourselves or someone that we care about. We will start with an introduction on the topic of stellate ganglion block in the treatment of post-traumatic stress disorder with Dr. Jim Lynch and Dr. Jeff Teedy. Dr. Lynch is a primary care sports medicine physician who co-founded the Stellate Institute after serving 31 years in Army medicine. Skilled in both physical and mental health issues, Dr. Lynch has supported elite Olympians in international competition and has also deployed to Iraq, Afghanistan, Syria, and throughout Africa in support of special operations forces. Dr. Teedy is a pain management physician who serves as director of the Center for the Intrepid at Brooke Army Medical Center in Fort Sam Houston, Texas, which executes the Special Operator Performance and Recovery Program, addressing human performance, musculoskeletal injuries, and comorbid conditions such as post-traumatic stress and post-concussive symptoms. Colonel Teedy has also served as command surgeon for the 101st Airborne and currently commands the 5th Brigade of the 94th Training Division in the Army Reserves. Dr. Lynch and Dr. Teedy, I'll start your slides and then the floor will be yours to go over the underlying challenge, or the 5 W's, of stellate ganglion block.
Great, thanks, Lindsay. While you're pulling up the slides, I just want to say thanks. It's an honor to get to talk to this topic for this venue, since really the roots of stellate ganglion block came out of the special operations community, and specifically within several Tier 1 or SMU special mission units back in 2010. And my partner at the Stellate Institute, Sean Mulvaney, was instrumental in starting this. I'd be remiss not to mention his name right up front. We work together every day in Annapolis, Maryland on this. So my goal is, I think we're going to circle back multiple times, but my goal is just to start off with just some nuts and bolts in terms of what a stellate ganglion block is for anyone that's on this call that just hasn't experienced it at all. So right up front, hopefully y'all can see the slide in front of you. This is just a picture of me performing a stellate ganglion block, which is simply an injection in the side of the neck. I'm using live ultrasound to guide a needle precisely to a target in the side of the neck and delivering a long-acting anesthetic there. It sounds crazy if you've never heard of this before. It's actually something that's been tried and true for many, many years for other indications. But just if you haven't seen it, I want to at least give you an idea of this is what it looks like. The procedure is conducted in an outpatient setting. It only takes a few minutes. It's extremely safe and not painful. So it sounds a little unusual if you've not heard of this before. Next slide, please. In terms of the bottom line up front, like I mentioned, the stellate ganglion block is an injection to a nerve in the neck. The nerve is actually the cervical sympathetic chain, which is a trunk that runs on both sides of the neck, on the left side and the right side. And it's essentially a two-way highway that connects the brain to the body, carrying the fight-or-flight system. So most people are familiar with that terminology for the sympathetic nervous system, the fight-or-flight system. And what the local anesthetic does is it actually blocks or turns off the nerve for about 8 hours, which is the duration of the medicine ropivacaine. And when it wakes back up again, it wakes up in a less excited state. That's kind of the simple version. We'll dig into more about that later. Stellate ganglion block is not new. It's not a fad. It's not something we just discovered. It's been around for 100 years. It has been used for many, many other indications, primarily in pain medicine, but also in things like cardiac medicine and respiratory medicine. It's not something new, but several years ago, we kind of stumbled upon an additional indication for it, which it could be used extremely effectively to help reset the fight or flight system. Because it's been used for 100 years, you can imagine it was safely used, for 80 years before the advent of any kind of ultrasound guidance or fluoroscopy guidance. It's an extremely safe procedure and used to be conducted by simply touching a bone on the side of the neck and following a needle next to that and injecting a local anesthetic. And that was done for thousands and thousands of people for many years since the 30s and 40s. As far as the indication for PTSD, we've now treated thousands of people for that specific indication for post-traumatic stress symptoms. And we've been doing that, and the research has been published. A lot of it has come out of the Stellate Institute by myself and Dr. Mulvaney, the majority of research that's been published, but it's been studied in other centers as well. And I'll talk about the evidence to support it. But suffice it to say, it has level 1B evidence. It's extremely high on the evidence ladder. And this is not something that is some fringe medicine that doesn't have evidence to support its use. I'll talk the specifics on that. There's currently 40 articles that are published in the literature. If you go back to the earliest report, which was a case report describing a young woman who was treated with stellate ganglion block for pain, and her PTSD symptoms got dramatically better. And that's how the first report came about. There's about 18 studies that are published in the peer-reviewed medical literature that are original research, again, that are actual studies reporting outcomes for post-traumatic stress symptoms. The bottom bullet down there on the slide is really what was published in JAMA Psych a couple of years ago now, was a large randomized controlled trial that was something that both Dr. Titi and I took part in. It was a Department of Defense study that took place between Tripp Hospital in Hawaii, Landstuhl in Germany, and Womack Hospital at Fort Bragg. It was a large trial that compared the stellate ganglion block procedure compared to a placebo procedure, or what we call a sham procedure. And essentially, there was twice the effect in the stellate ganglion block as there was in the sham procedure. When that was published in JAMA Psych, we really thought that would be, kind of a tipping point for this. And we're still pushing the rock up over the hill, so we'll see about that. Next slide, please. So in terms of what's the effect, and I think we have plenty of time to dig into the finer points here. I'm really trying to give you the wave tops. But when we talk about what's the effect, these are consistent across the literature. So whether it was a small case series early on, whether it was a large case series like the series that we published out of the SOF community early in the 2000s, there was 166 cases. Essentially, the effects and the success rate has remained pretty consistent. So while there's this one large randomized controlled trial that we did in the military several years ago, if you look at all of the evidence combined together, which are like the lower level studies, for lack of a better term, there's essentially a 50% reduction in PTSD symptoms that's immediately. So that usually happens within hours, certainly less than a day. And that's persistent for a period of time, depending on the individual, which I'll talk to. But 50% reduction in symptoms is pretty dramatic. What's considered a success, if we look at the score sheets that we use to track symptoms for PTSD, is most people will say a 10-point drop is considered a minimal, clinically significant difference. When we start talking about dropping rates in half, that's pretty profound, and that translates for most people to a pretty dramatic effect. On the slide here, I say 80% of patients within hours. I think what we're seeing now is slightly higher success rates now that we've modified our technique a little bit to include blocking the cervical sympathetic trunk, not just at the C6 level as it's been traditionally performed, but at both the C6 and the C4 levels. And I'll talk to the finer points of that. The additional thing that's increased our success rates is now looking at treating non-responders with a left-sided stellate ganglion block. Also, I'll talk to that, but just a teaser to say that this is actually something that we're still developing the finer points on treatment. And as we do that, we're finding ways to make this more successful. Many people ask, how long does this last? I can tell you it's all over the map. There are people who are one and done that we've treated years and years ago. They got a single stellate ganglion block, did awesome, continued to do therapy, and eventually maybe came off their meds slowly over time with the consultation of their physician. But there are those people, that's the minority. There are the people who don't get that much better after the first block, but might take a second or a third block. And then there are the people that will get much better dramatically, 50% drop in symptoms, and then maybe have their symptoms creep back up again before the 6-month mark. A lot plays into that. And primarily, in my experience and the experience of the hundreds of patients I keep in touch with, is the compliance with therapy really becomes a key part. So just to reinforce that part, which I'll do about 10 times tonight if I can, the stellate ganglion block is not designed to replace some other therapy. If anything, it's designed to be added to what already exists for tried and true traditional PTSD treatments. The mainstay of that are several different types of talk therapies. And we'll hear from others throughout the night about this, but that's a really key point for stellate ganglion block, is I think in concert with good talk therapy, really the duration of effect gets extended significantly. Just the last couple bullets there, and then I want to shut up and turn things over here. We did conduct a study to look at what behavioral health providers found in their experience with stellate ganglion block. So just a couple of years ago, we published this, and we canvassed all of the psychologists, social workers, and psychiatrists in the US and Europe who had any experience at all with taking care of patients of theirs or clients of theirs who had a stellate ganglion block. And then we published these experiences with it, which if there's anyone on the call tonight who's a psychologist or social worker interested in this, I refer you to our website. We hung the full text journal articles of all our articles on there. But this is a very interesting one because it shares with all of us what the experience has been from the psychologist and the social work community. And 95% of psychologists who have experience with SGBs would recommend using an SGB or adding an SGB on to their behavioral health colleagues. And there's much more detail in that study as well. That's just kind of the one up front. So again, I already highlighted that last point there. Again, the stellate ganglion block is really not designed, and in my experience with treating hundreds and hundreds of people, it is not designed to replace therapy, but it can dramatically enhance standard treatment by making people dial down the fight or flight system, dial down the physiologic responses that go with PTSD, make people more calm in their bodies to undergo therapy for trauma. I'll pause there. I know we have lots of time to come back. Dr. Titi, I don't know if you have anything to add up front.
Thanks, Dr. Lynch. Just an excellent summary, and absolutely concur with everything you said. I think the people on this call, may not know us from Adam, but a couple things to stress. The simplicity of the procedure. When you think about someone injecting something into your neck, this doesn't sound like a very comfortable thing to do. After doing a number of these under fluoroscopy, under an X-ray machine, the change in practice to do them under ultrasound guidance, it's game changing. It's revolutionary. I could tell you soup to nuts, which is a term I learned from Dr. Lynch. Prepping whole thing, I could be done in roughly 2 to 3 minutes. And I can't tell you how many times that I've had a patient finish one and they said, "That's it?" And I'm like, "Yeah, that's it." So to take a little bit of the fear away from it, because especially in the past, when I trained as a fellow back in 2004, this was a 20-30 minute procedure in skilled hands. But now the technology has changed so much that really it's I wouldn't say without fear, but it's really does minimize the impact of the procedure as far as of the scariness of it. And then one other thing that you mentioned, Dr. Lynch, is the extent of the studies. And so you may think to yourself, well, 40 studies, or has this really been looked at, or does this need to be looked at anymore? And yes, in comparison to large multi-center cardiology studies, drug studies, we're never going to develop those numbers. But from a pain management physician standpoint, there's more literature behind this than there are nearly everything else that we do in my practice. So the literature to support it is robust, and it is growing. And I think that Jim and I will talk a little bit more about some of the ongoing studies. But as far as being a procedure that no one's really looked at, or that there's really not good evidence to support, that simply just isn't the case. We have, as you mentioned, 1B level evidence, which is very high quality when it comes to an intervention, much more than a lot of the surgical interventions or other procedures that we do.
Well,
anyway, that's my 2 cents. Yeah.
Thank you very much, Dr. Titi and Dr. Lynch. That was a great intro to the procedure, and we'll get down to lots of the details a little bit later on. But right now, we're going to hear from our experts on psychedelic medicine. Dr. Lynette Averill is a clinical research psychologist at the VA Medical Center in Houston, Texas, and an associate professor of psychiatry at the Baylor College of Medicine. Her clinical and research expertise is in the psychoneurobiology of suicidality and PTSD and psychedelic medicines. She serves as a founding board member for Source Research Foundation, a nonprofit focused on expanding psychedelic research, and Reason for Hope, focused on policy and advocacy. And Dr. Robert Kaufman is a Navy captain and psychiatrist and the senior consultant for integrative medicine and behavioral health at the National Intrepid Center of Excellence in Bethesda, Maryland. For more than 2 decades, he has provided behavioral health care services for service members in a multitude of operational settings, including Iraq, Afghanistan, and even Antarctica. Dr. Kaufman is a passionate advocate for increasing access to non-stigmatizing psychological services. Dr. Averill and Dr. Kaufman, please give us the 5 W's on psychedelics.
Thank you very much. I think to echo what Dr. Lynch said, it's really an exciting thing to be able to talk with this population about this intervention or about these interventions. I think there's an incredible amount of interest in this, also an incredible amount of misinformation, an incredible amount of things that are sort of being bandied around that may or may not be correct. So really excited to be here and have the opportunity to chat a little bit about these things. I think we'll do sort of a similar thing. I will kind of rattle off some bits of information and then turn the time over to Dr. Kaufman, who can comment on any of his insights and wisdoms, things that I may have left out, et cetera. So just to set the stage in terms of what psychedelic medicines are, what we mean when we refer to those things. Psychedelic medicines are very powerful pharmacologic agents that include a number of things. Some medicines likely you have heard of, maybe all of them you've heard of, Ketamine is one that is sort of an interesting thing, and depending on who you ask, it is formally a psychedelic or it is a psychedelic-like medicine. But other things that are more traditional psychedelics include things like psilocybin, which is the active ingredient in magic mushrooms, MDMA, which you may know as ecstasy, ibogaine, 5-MeO-DMT, ayahuasca. Any of these things are psychedelic medicines. Something important to note about these is that neurobiologically, in many ways, they do work similar to some of the ways that our traditionally available antidepressants work, our SSRIs and other things, where they may modulate serotonin or other sorts of things. But they also seem to interact very significantly with other things, most notably the glutamatergic system, which has a lot of effect on synaptic connectivity and these kinds of things. The thing that I think is very exciting about psychedelic medicine, and certainly has led to a lot of the interest in these medicines, is that relative to SSRIs and other interventions that we have, these seem generally to work much more rapidly and much more robustly. So often, when we are prescribed an SSRI, something like Prozac, et cetera, it takes weeks to months before these actually cause clinical effect, before people actually notice a change in symptoms. And unfortunately, for many people, they don't experience a change in symptoms, and there are significant side effects, et cetera. These medications generally, for people who respond, that's a very important note. These are not a panacea, not a golden bullet, not a one size fits all. Not everyone will respond the same way. For people who respond, though, generally the response happens in a number of minutes to hours to days, which is incredibly different than starting an SSRI and waiting weeks to months. Particularly if we are thinking about someone significantly struggling with depression, post-traumatic stress, suicidal thoughts and behaviors, telling you to wait weeks to months with the hope that something is going to kick in and take the edge off, unfortunately, all too often is actually a fatal thing to tell people. That's a very dangerous period while we wait for those to kick in. An important note about ketamine, that does have FDA approval. It's had FDA approval for a very long time. It was born, if you will, in the Vietnam War as an anesthetic, and more recently, a version of ketamine, S-ketamine, received FDA approval for major depressive disorder. MDMA and psilocybin both currently have what is called an FDA breakthrough therapy indication. And what that means is that they're kind of being fast-tracked through the FDA approval process because all of the evidence suggests that these interventions are safe, are effective, and work just as well or better than the currently available and approved interventions. MDMA is expected to have FDA approval likely next year, and psilocybin probably in 2025. A very important note about these medicines, I think similar to what Dr. Lynch said about stellate ganglion block, is that these are not intended as a standalone. I would strongly discourage anyone from taking this medicine simply as the medicine. I think that the medicines really serve as a foundation, a catalyst, that they open up space. They do a lot of lovely things neurobiologically that get you into a better spot, perhaps emotionally, cognitively, neurobiologically, to actively engage in the psychotherapy. And the psychotherapy is really the critical piece. If you're familiar at all with psychedelic medicine and assisted therapies, you may have heard the terms set and setting. And what these really refer to is that at the beginning, before you engage in the treatment, that you really spend a bit of time and a lot of thoughtfulness, a lot of caution in thinking about why are you engaging in this intervention? What are you wanting to get from it? What are the intentions that you want to be setting? And also importantly, setting expectations. I think especially whenever there is an intervention, whether it be stellate ganglion block, psychedelic medicine, anything, when there is a lot of hype about something, a lot of interest, expectations can can kind of get in the way. If we have a very profound expectation, and then, you know, sometimes it's hard if the experience doesn't necessarily match our expectation. Whether the reality is still very positive or not, if it's not exactly what we expected, that can alter things a bit for us. But really setting the intentions, also in terms of the expectations, understanding that, you know, I think something that I've always found to be fascinating about psychedelic medicine long before I was engaged in research in them is that for people who use these as an intervention, it is not at all about getting high. It is not at all about having fun. These are often incredibly difficult, incredibly meaningful experiences. I had heard many people talk about it like having a surgery without an anesthetic, going through 6 months of intense trauma treatment in the course of a weekend, these sorts of things. So preparing yourself for that this will be a challenging experience because these medicines and the accompanying therapy really very rapidly and robustly may be bringing things up like trauma exposures, like guilt, shame, forgiveness or lack thereof, demoralization, any of these kinds of things that are not necessarily pleasant or easy to be discussing and working your way through. And I think it's very critical that you set those intentions, you set those expectations, and that you also have a very trusted support system and plans for integration and processing of all of the things that came up. You know, that's the sort of piece of setting, that you ensure that you have a safe space, you have well-qualified facilitators to get you through the experience, that you have done everything you can to ensure that you are safe and appropriate. Certainly right now, psychedelic medicines, generally speaking, are illegal within the United States. So the way that you would engage in those, psilocybin, MDMA, ayahuasca, otherwise, are either by leaving the country, which many of our special operators have done, or by finding a facilitator and engaging in these in the underground with someone who can provide you the intervention, or through clinical trials. Being an active duty special operator engaging in a clinical trial with a Schedule I drug is not without its challenges. But a very important piece of that is that you ensure that you are safe and appropriate to engage, just as you would with stellate ganglion block, with any other kind of intervention. These are powerful medicines. They are absolutely not without their risks, either in terms of physical health complications or mental health complications if things are not done appropriately. One thing that I think we'll come back to also is that should you find yourself in a position of engaging in these outside the context of a clinical trial, that it is critical that you very carefully vet the program that you are considering, that you ensure that the people are well qualified to be doing this. Talk to your comrades. I think the special operations community has been generally very active and engaged in this sort of work, in this intervention. Some of the resources that we've shared include some groups that could provide some information and consultation and things. And I think, you know, being just very cautious about what this may look like. There are many other things that I will say. I think I will leave it there though, and see if Dr. Kaufman has any other things that he would comment on at this point.
Thank you, Dr. Averill. And again, it's a pleasure and an honor to be here tonight, speaking with you all on a subject that really is on a lot of people's minds, and that is the so-called Psychedelic Renaissance, which is exactly what we're talking about and why we are here to enlighten you this evening. As Dr. Averill was saying, we are in the midst of this explosion of interest with psychedelics, when in fact psychedelics are still considered a Schedule 1 substance, meaning that there is, according to the FDA, no known medical use and accompanied by a high addictive potential. So actually, neither of those are in fact true, which is why, as Dr. Averill mentioned, FDA is going to end up rescheduling MDMA ecstasy probably by next year. If not next year, then the year after. And psilocybin has already been rescheduled with caveat in Oregon and many cities, such as right here in DC, Denver, Oakland, other cities and counties have also decriminalized psilocybin. There's a real move afoot, and I think we'll be talking about this in terms of, are we getting ahead of the research? And we really do need to talk about where we are today. Both Dr. Averill and myself are conducting research with these Schedule 1 medicines, and we refer to them as medicines as opposed to drugs, to help destigmatize the 60s when research basically stopped for all psychedelics. We really have 40 years, 50 years of research to catch up to. But these Schedule 1 medicines or substances are now being appropriately evaluated, and subsequently in our discussion tonight, we can update you on the status of the research. Over.
Thank you very much. That's we've had a ton of questions already rolling in the chat. So I wanted to go ahead after that thorough introduction on both these different treatments. Go ahead and pass it on to Eric, who's going to lead our question and answer period.
Thanks, Lindsay. And thanks for everybody for all the questions. We've actually received a wide range of excellent questions, from basic to some very intense questions. They will all be looked at. So I'm going to go ahead and answer some that we have received prior, and then some that we've gotten on the spot that we've kind of found to be of great impact initially. So this is based for psychedelic medicine. This is one that we got earlier. Would this be helpful for a TBI diagnosis? Appears to be from 2013. For multiple concussions with focus on sleep and breathing issues. That's the first one.
So I think I would say, again, there's not sort of a blanket statement without knowing a bit more information, about the individual's health or those sorts of things. Certainly, I know one of the questions did ask, maybe it's this one or a different one, did ask about, is psychedelic medicine and assisted treatment effective for individuals who had sustained TBI or some sort of post-traumatic experience, or now is having post-traumatic symptoms from events long in the past? And I would say absolutely. Many people who engage in these interventions are perhaps working on managing symptoms that not only are perhaps from earlier military service, but often from childhood even. The unfortunate reality we know about our service members is that many of you came into the military already with a bit of a background in stress and trauma. And that certainly these interventions do not have any, best if used by date. You can use these at any time and people can experience significant effect. Many people with traumatic brain injury have used these. Certainly Dr. Kaufman can speak to that, but many of the people who have been engaging in these are special operators. And of course, special operators often have experiences with TBI. To the comment of sleep, I think certainly that is an area that there's a lot of interest, particularly with psilocybin. There's a lot of interest specifically in sleep. But I think we know that sleep is a critical component and kind of this mutually exacerbating and or mutually benefiting sort of component with mental health symptoms, that impaired sleep can exacerbate or worsen those symptoms. And also as symptoms improve or sleep improves, you may notice symptoms or sleep improving in tandem. I don't remember the rest of that question, if I've answered all of that or not. Bob, is there anything else that you would say about that?
I'd like to add just one consideration. The psychedelics have really shown us or brought to us an entirely new lexicon of medical terminology. In fact, there's actually a characterization now called a psychoplastogen. Psychoplastogen meaning plastic or repair producing. The psychedelics as a class are capable of immense neuronal regrowth, whether that's synaptogenesis, making new synapses and connections, spinogenesis, the supporting structure of the neuron. There literally is an explosion of new growth following a psychedelic administration. And that is the focus of some really exciting research right now that actually there's a couple of nonprofits that Lynette and I are working with that are going to be looking at the use of psychedelics for repair of TBI as well as other neurodegenerative diseases. We typically think of psychedelics as being useful for psychiatric conditions and serious mental illnesses. We may find, again, because the research was halted for 50 years, we may find that psychedelics are very helpful in brain repair. Over.
No, that was excellent. Actually, you both answered about 2 or 3 other questions that were kind of posed, and which is great, right? Because everybody's kind of trying to get to the same thing. And in particular, I think the key that we've seen in some of these questions is folks in some special operators or just folks in the military that got hurt and are going, hey, well, this happened to me 10, 15 years ago. Am I a lost case? Or is it just for new operators that just came back from Afghanistan and are hurt? So it's great to hear that does encompass it and that there are treatments. You just got to get started. So I think that's important. And so on that note for SGB, there's one that says, and this is back to sleep, which everybody cares about. Do studies show any impact on outcome of sleep? So anything that you can comment on anecdotally?
Yeah, I'll take that. So good question. Just to piggyback off one thing, the question about TBI that comes up for SGB, I'll just answer that too in case that circles back around. So what stellate ganglion block does is it actually changes cerebral blood flow, and this has been studied both in animals and a long time ago and in humans. So when we started adding left-sided blocks to SGB, what we found is a lot higher response in people with history of TBIs. None of this is published. None of this is data that I can point to a specific article, but both myself and Dr. Mulvaney, who've been doing this for 10, 12 years on hundreds, thousands of people, and a lot of them with blast exposure, have noted this anecdotally. We feel strongly enough about it that we will alter our treatment based on people's history of TBI. But it's not to the extent that I would slap the table and say that SGB treats TBI symptoms, although as we know, there's tremendous overlap with PTSD. As far as sleep goes, this we actually have published. So in terms of the symptoms that stellate ganglion block is most effective for, and that's what people want to know a lot of times, because to me, it's not helpful to say this treatment is helpful for PTSD. That's a little simplified, right? There's 636,000 different variations of symptoms that all equal PTSD if you use the strict DSM-5 criteria. So it's a super heterogeneous thing. And there are people with all different types of symptoms that have PTS. We treat people at the Stellate Institute and have been for quite some time, people from all trauma backgrounds. So the other thing is that what we describe as stellate ganglion block is not anything that's somehow specific to combat-related trauma or to males or to military backgrounds. We treat probably at this point more people with child neglect and abuse and sexual assault survivors than military veterans. And as you know, many military veterans have childhood abuse and neglect and sexual assault background and combat. So this thing is not simple. Having said all that, we've studied the effects of stellate ganglion block on specific symptom clusters. And this is published. So these articles are, again, hung on our website on the evidence tab, and you can see this with some nice graphics laid in there. But of the top 3 symptoms that were improved following stellate ganglion block, sleep was one of the top 3, with the other one being irritability and anger, and concentration. And those are 2 really weird ones to get after. If you talk about concentration and sleep, there's a lot of multifactorial input from that. There's also a tremendous amount of output that happens. If you can remedy someone's poor sleep and concentration, you think of the ripple effect that goes along with that. So those 2 in conjunction with irritability and angry outbursts were really kind of the big 3 that were demonstrated in a study that we looked at back at Fort Bragg years ago. The same thing was found in the large randomized controlled trial that I mentioned that was published in JAMA Psych just a couple of years ago. So that's the answer to the sleep question. Eric, I'm not sure if I hit all that.
No, you did, and actually, you guys are great because you're getting ahead of me. So this is perfect. And so I like to comment on, I did 2 of them about 2 years ago, and that was the first thing I remember not being able to do after, I don't know, 23 years of special operations was sleep, and I slept both those times like a baby. And one of them, I was going through the 1-month program at NICO, and I didn't even go back to that session the next day because they just left me to sleep for almost 14 to 15 hours. Somebody had to bring me food because it was amazing sleep. And so now, a year later, I'm actually looking for my 3rd to go do, just like you mentioned, where was I then? Where am I today? And what would this treat me, retune my ability for concentration and sleep, which I have a better grasp of. And so and Lindsay, let me know how we're doing for time, but I've got some here that I think that are simple but are good. And so, I'm going to mix 2 of them together. One of them is, how much does SGB cost compared to other treatments, right? And then on the administrative side, does it still require an intake process involving the PCL5 and the OQ45 questionnaire? And lastly, what kind of data is collected before the SGB? So I think these are good administrative people that are potentially interested, and they just want kind of this quick answer.
Yeah, this is Jeff Titi. I'll touch a little bit on the administrative data and really how this, in my practice at the DHA or the DOD, how this fits in and how I would expect it to be at a lot of the military treatment centers. Basically, there's no uniform outside of a protocol. There's no uniform data that we collect. There's no specific inclusion, exclusion that I do. The way I approach it is that I lean on my behavioral health providers. And if a behavioral health provider tells me that they've developed a relationship with the patient and they think that they would benefit from a stellate ganglion block, knowing exactly what symptoms are improved, the sleep, the irritability, the concentration, then I'm happy to do it. And I'll turn it over to Dr. Lynch for the rest of that.
Yes, I think my experience is a little bit different. So I grew up in the SOF community as a family med doc, working alongside a team of 2 psychologists and 2 social workers. We functioned as a team that way, and that's how I learned to bring stellate ganglion block into clinical practice. So I think so. Let me answer a couple of specific questions, which was within the DoD, if you're an active duty service member, there are hospitals that provide stellate ganglion block, just like Dr. Titi mentioned, down in San Antonio at Walter Reed at Fort Bragg in North Carolina, Jacksonville in Florida for Navy. There's several, and they come and go depending on, like the military is, as the doctors change duty stations. But there are some pockets that have been pretty consistent. Within the VA system, for you veterans out there, this is not widely endorsed by the VA right now as it stands. And there's a lot of efforts afoot, including ones that I've been personally involved with, and other people that are on this call have been involved with for many, many years, to try to get the VA to wholeheartedly endorse and then offer stellate ganglion block at all VA hospitals. We're a long way from that, frankly, and I hate to say it like that, but we're working that. And there are local spots within the VA. There's about 12 hospitals nationwide that will offer SGB. There are private organizations for all other people. So I mentioned that we take care of people from all walks of life with all trauma backgrounds. I happen to be located in DC with Dr. Mulvaney. We have people that fly in from all over the country who come to see us because they maybe don't have somebody nearby, or maybe the people that are nearby them are not experienced. Or as was previously mentioned, maybe they use fluoroscopy because that's how they were trained. And we know that that's probably not the best way to do this. Regardless, within the civilian world, there is no insurance company that will cover stellate ganglion block for PTS, period. There are things working that way, but essentially then if you're outside of the military system where it's available to you, or the veterans healthcare system close to you, and you have to seek care at a civilian provider, it's essentially an out-of-pocket cost. I can tell you that we charge about $1,000 for a stellate ganglion block at our center, and we've done more than anybody else in the entire world. We publish more research on it more than anybody else. We're the world experts, and we charge about $1,000. We offer a discount for veterans because we're veterans. We kind of grew up that way, so we offer less for veterans. There's also a lot of benevolent organizations that will sponsor or kick in funding to support veterans or family members who desire a stellate ganglion block, and they will help cover the cost or defray the cost of treatment and get you to a place that does a high quality stellate ganglion block. To that end, what we require at our institute is a screening done ahead of time. That we use a PCL5, which is the PTSD checklist 5th edition, which is a standard screening tool. It takes like a minute to fill out. It's 20 questions. It's a standardized tool. And we also use a GAD-7, which is a generalized anxiety tool. The reason we use that is there happen to be many people with bad generalized anxiety who do very, very well with stellate ganglion block. And a lot of them just have not been diagnosed with PTSD while they have trauma in their past. So as to try to open the aperture and make that a little more available, we like to weigh all those things. And there are some very specific anxiety symptoms that we know will respond very well to SGB. I think that answered the screening question and the cost roughly. There are other people that will charge much more money out there in the civilian community that'll charge like $3,000 over the $2,000, and they'll, they may have very little experience at all. They may perform the block under fluoroscopy. They may not really have any time with the patient. Myself and Dr. Mulvaney, we came out of the community, so this is how we were raised, but we each spend about an hour and think that that's a
but you didn't.
Ooh, I think we had a hot mic. Anyway, that's probably my cue to shut up. I think that's important because it's part of the care that goes on, is to do a high quality procedure under ultrasound guidance with plenty of time to actually address and share the lessons learned. So all those things kind of matter. Hopefully that answered the question. Thanks, sir.
No, it did. That was excellent. I think hopefully that will have people going towards, the treatment. And so on that, for right now, I think I need to hand that back to Lindsay.
Yes, well, it's great because we're naturally getting to, sort of the next topic that we had here, which is a little bit about the controversy. You've already talked about the evidence that is out there that's quality evidence, and then the effectiveness that's possible as well. But if we could focus on the ethics, I know it's a touchy subject to try to not name names, but if there is a way that each of you could talk a little bit about how do you find a quality treatment option, for these and pursuing that with your doctor. Dr. Lynch, do you want to go ahead?
I'll go. So I retired last year. I spent 35 years in the military. I love being a military physician. I'll just say that because there's probably some people out here that are like, oh man, I hate military doctors. I'll just say it. There's probably somebody out there. The reason why, and now that I've been in civilian practice for a year, so the reason why is you can take really good care of people and never have to worry about any finances. No one making any money off anybody, no one spending a dime, not insurance approval. You can just do the right thing as a military physician, and I cherish that. I miss that frequently. Okay. Why does that matter? Because now, whatever, all good things come to an end. And I find myself in the civilian world every bit as passionate as I have been for the past 10 years in the military in terms of trying to offer what I believe, is my passion and my life's work, which is things that truly save and change lives. Okay, so to do that, I think that's important to know that there's somebody who is trying to keep that pure. So I mentioned that we offer some discounted costs. And what we have tried to do, both myself and Dr. Mulvaney, is kind of stay true to our roots here. And because we have to do something to charge money and insurance doesn't cover it, we have tried to make our cost to our veteran colleagues and teammates our break-even cost. So essentially, we're not making money off our veterans. It's still is the kind of thing that until we can get this covered by insurance, or until we can get the VA and DC to start doing this, which is a short drive away from me, until that happens, we're stuck with this little bit of a gap, I guess, for lack of a better term. What I believe is that there's a tremendous amount of benevolent donors who I think would willingly put down a few bucks to help cover the costs for veterans to seek care. I wish there were an equal number of benevolent organizations to take care of rape survivors, frankly. I think that that's tremendously overlooked, as well as first responders. And there are people out there who are willing to try to help defray the costs of these life-saving treatments until insurance catches up. Like I mentioned, it is what it is, right? So we're stuck in this kind of limbo until that happens. And in the meantime, we'll continue to work on things like the Treat PTSD Act with our friends in Congress to try to get attention to this, to get more widespread efforts across other organizations. When the VA does broaden the approach, I think it's critical that people who've been doing this for a long time are involved in the training and kind of, share our lessons learned, so that we know that our veteran brothers and sisters are getting the same care that we have fine-tuned, if I can say that, over the past 10 years of really, learning from our colleagues, learning from our patients, what makes this really work. And it's not just a simple go in, a doctor says hi, marks your neck with his initials, sticks a needle in your neck, sedates you unnecessarily, which I'll just say that now. If anybody is sedating you for stellate ganglion block, it's unnecessary. It's not only unnecessary, it's probably more unsafe, or it's less safe. Why? We know that. This is published in the evidence, and Dr. Titi can attest to this, that within the pain literature, a sedated patient is usually less safe if they can't provide the feedback that we need while doing a procedure. And of the hundreds and hundreds of these I've done, I don't know how many other people, my patients like Dr. Titi, sit up and they go, "That's it?" Or most people I say right after the procedure, I say, "Did that hurt?" And they go, "No, felt weird." Almost everybody says that, "Felt weird, but it doesn't hurt." So why you would sedate somebody unnecessarily and with the risk that goes with sedation seems crazy to me. Why would you do it under fluoroscopy just because you were trained that way, where you can't see blood vessels and there's a tremendous amount of anatomic variation in the neck? Seems crazy to me. So these things to me are, it's difficult to be in this position where I feel like I'm throwing stones. But in the interest of taking care of patients, I think those are little flags that you should be aware of. And when somebody says, "Well, I've done lots of stellate ganglion blocks under fluoroscopy and I haven't had a problem," you only have to watch a few before you realize how many times they're skewing your vessels before you realize, okay, no thanks, I'm going to go with the ultrasound. So I think there are points to that I would, in the spirit of sharing this with my family, the SOF community, I would look for people who genuinely care about you. They genuinely care about providing a safe and high quality procedure, and they're not out there to just get a couple $1,000 off some benevolent organization that will foot the bill, like some of these larger VSOs. So I think you got to be careful with that. Until it's more widespread, that's tricky business, but that's the advice that I would share in terms of ethics. Thanks, Lindsay.
Dr. Averill, Dr. Kaufman, do you have any similar tips for psychedelic medicine?
So yeah, I think in terms of finding quality care, is that sort of the question here? I mentioned that sort of briefly in my initial comments, but I think because these remain Schedule 1 medicines, at least psilocybin, MDMA, et cetera, ketamine is fully legal. You can get, well, I shouldn't say fully legal. It is not a Schedule 1, so you can go, get that at many clinics. Talk to your doctor about that and get a prescription for that and go use that. Psilocybin, MDMA, ibogaine, ayahuasca, any of these things, though, are illegal within the United States unless in the context currently of a clinical trial or very, very limited options for expanded access or compassionate use programs. MAPS, which is the MDMA organization, does have a couple of these throughout the country. And as a note, Dr. Kaufman and I actually were involved in some testimony for Connecticut, who is considering an expanded access program for psilocybin and MDMA. I think though, whether you are considering leaving the country, which many special operators do, and some of the resources that we've provided are for organizations specifically who are founded by special operators and help special operators to explore these sort of interventions outside the country and sometimes within in terms of ketamine treatment. It is critical that you carefully vet these programs because, as you can imagine, you likely can imagine, there is a lot of money to be had in psychedelic medicine. There is a lot of money to be had, unfortunately, anytime people are struggling, anytime someone is looking for something with any level of desperation, there are always people who will take advantage of that, unfortunately. So there are absolutely providers, facilitators, therapists, any of these things who are either perhaps going to take advantage of someone from a financial perspective, or just as importantly, and perhaps in many cases much more importantly, may take advantage from other perspectives. These medicines do put you in a vulnerable state. There unfortunately have been instances of sexual assault or of other kinds of things happening, which is not unique to psychedelic medicine, but is a very significant concern. That you want to make sure you have vetted the program, that you know who you're going to be working with. And again, I think because special operators have been so engaged in this space, it's quite likely that either through these organizations or sort of other word of mouth, that you can find members of your community who can give you some feedback on where is good to go and maybe also where is not so good to go. I think that piece is really important. I think also talking with your physician, which again, in active duty, I certainly understand can be challenging, and I think there certainly seems to be, from my experience with the initial conversation here, seems to be some interest and support. So your primary care physician may or may not be very supportive of you if you say, hey, I'm really struggling with what I've got going currently and need something else. This is what I'm considering. I think though, certainly being very honest with yourself and honest with your medical provider if you have any sort of cardiovascular risks. Most all psychedelic medicine are going to increase your heart rate and your blood pressure. If you already have increased heart rate and blood pressure, uncontrolled hypertension, any of those sorts of things, you're going to be at greater risk for a negative sort of experience in that way. So being very thoughtful about that. I think also just really making sure that you kind of, I suppose, put in the time to make sure that you feel safe, that you have kind of set up the experience appropriately. I think because these are such powerful experiences, you don't want to, kind of jump into it impulsively and decide after work on a Friday, well, yeah, it's been a rough week, I need something, and just go buy something on the street. For a lot of reasons, not only for the idea of setting intention and making sure that you're safe and supported, but also you have no idea what you're actually getting. I think for also the process of vetting the programs that you may consider, retreats outside of the country, or if you are engaging in this or considering engaging this in the underground, really asking questions about the process, the therapy, the product, what is it, where are they getting it, any of those kinds of things, so that you can go into the experiences with the best possible sense of safety, of ethics, of any of those things. Are there other things that you would say about that, Dr. Kaufman?
Thanks, Net. I was about to say that your word of caution is very well founded and should be taken in stride by all. Just because of the fact that these medicines have grown on God's green earth and have been used for thousands of years by largely indigenous people, there's a nonchalance about them. And as Dr. Averill was pointing out, that there are many more underground avenues for treatment than there are above ground, and the above ground are really, in fact, here's the clinical, NIH maintains a clinical trials website where you can find research such as the research that Dr. Averill and I are currently doing on with MDMA and psilocybin in a location near you. Keep in mind that it's very difficult to get enrolled in these trials, but these are totally above board. They are monitored, and they are with all the safeguards that Dr. Averill was cautioning you. Over.
That's wonderful. All good information. Thank you for dropping that link. And just as a reminder to everybody, we do have a resource page where we have the resources listed that the presenters have already provided to us, and we'll be adding any more resources that we find as well to that page. And we'll send that out to all of your emails tomorrow, probably, once we actually get all the new links in there. But something else that I wanted to talk about, if I could, for just a minute, is a little plug for MSOF, the Military Special Operations Family Collaborative. And what we are trying to do is be that sort of clearinghouse, that place where people can bring their experiences, who to go to, who they've trusted, who they might have had a bad experience with. And then that way will be that trusted place that other operators and family members can come and find what works for them. And so maybe for, an active duty family who can't take advantage of the less than legal opportunities, we would be able to advise them on what are legal and safe and effective and ethical treatments. And then others who have different options can find the resources that work for them as well. So that's just a plug to please. That's why we're having this conversation, bringing in these experts, inviting you all in to participate and ask your questions, is because that is what our mission is right now, is to get those resources out to folks who need them. So, but I'll turn it back over to Eric. I was hoping that we could now get to some questions that are more about how to specifically engage your primary care provider on seeking these interventions, but then also how to talk to your family about it. Because at MSOF, we really believe that every person in the family has a role in everyone's health and well-being. And so we really want to make sure that everybody's communicating with their loved ones.
Thanks, Lindsay. I think it's been great that the panel has actually covered a lot of questions. So I'm actually having to go back into the questions and listen and then kind of check them off. But one topic that it's still kind of highlighted, and it's based on suicide, right? So we've kind of mentioned, SOF operators or folks in the military, current or post, seeking, these two key treatments, and we've kind of talked about sort of suicide. And then so the question would be, I'm going to read a question, but it deals with how do we get to folks that are potentially suicidal, right? And so the question is for SGB and psychedelic medicine, and it's two-part. So I'm going to go through the first part, and then I'll let the panel kind of answer it. So any implications or potential developing evidence-based practices in relations to self-harm, crisis, and suicidal ideation and behavior. And so what they've tacked on, which I like, is a study, right? So hear me out. 2 years ago, SOCOM commissioned a study to address the salient issue of suicide across the force. The study discovered that from 2007 to 2015, 117 members of SOF Enterprise committed suicide, a number that was almost 30% higher than the next closest military unit and almost double of that for equivalent civilian population. The question, with current research being conducted at some of the premier research universities across the world showing promising and enduring effects, are there any current or planned psychedelic assisted therapies for active duty soldiers? So it's a compounded question, but obviously to the point of, are any of these helping our warriors who are having suicidal ideation?
So yes, I'm excited to say yes. There are a couple of papers that that will be included in the resources page. One is, I will say that to date, there have not been any randomized controlled trials that have specifically evaluated the anti-suicidal effects of psychedelic medicine, with the exception of ketamine. Ketamine does have some studies that specifically have evaluated the anti-suicidal effects, and those have been very positive. Studies for psilocybin and MDMA always include some suicidal thoughts and behaviors items. But I think, as Dr. Kaufman or maybe someone else pointed out a little earlier, often individuals who are experiencing really heightened at all suicidal thoughts and behaviors are often excluded from research trials as a safety precaution. So those are always tracked, but not necessarily in a way that we can have a lot of confidence about how the medicines may or may not work. There is a study that I will share that was kind of a naturalistic study done by Johns Hopkins that included over 100,000 individuals who had used psychedelic medicine. I think these are kind of mixed medicines and interventions, but found that generally it was very positive in terms of anti-suicidal effects, and their sort of conclusion is that there may be a lot of benefit there. Our group here in Baylor currently has a grant pending that would evaluate psilocybin relative to ketamine for more acute suicidality. That's really a challenge, I think, in psychiatric research broadly, that we often try to study suicidal thoughts and behaviors without actually studying people who are currently actively suicidal. So it's a very challenging thing to sort of know what the research has said about many things. So we would be bringing in individuals specifically that are struggling with suicidal thoughts and behaviors at a higher level. I will note one of the other papers that we include, my colleague Alan Davis and I and a couple of others published on a sample of special operators who went to a clinic in Mexico and engaged in a treatment of 5-MeO, DMT, and Ibogaine assisted therapies. And some of those individuals did have suicidal thoughts that they were struggling with. And something that we know about many of the special operators who have engaged in these interventions is that, unfortunately, for many of them, they engage in these as sort of a moment of a Hail Mary pass, if you will, that they have tried everything that their traditional interventions seem to be able to offer. Many of them, have had 15 different prescriptions. They're taking prescriptions to manage the side effects of the prescriptions, and they're still not feeling that well. They may have engaged in yoga and equine therapy and TMS and, all of these things, and still are struggling significantly. And so go and engage in psychedelic medicine as sort of the last ditch effort. And certainly I have had the opportunity to talk with many individuals who found great healing in that Hail Mary pass sort of experience. So I would say that while there is not a lot of controlled research yet There is a lot of anecdotal evidence that suggests these have very useful anti-suicidal effects. From a neurobiological perspective, Dr. Kaufman mentioned the synaptic connectivity piece. That's one of the things that's really interesting and exciting about these interventions, is the very rapid and robust effect on synaptic connectivity. And we think that that's one of the reasons that there is a very rapid and robust reduction in many stress and trauma related symptoms, but certainly notably in suicidality. Is there anything else you would say about that, Bob?
Yeah, Net, thank you. Just with regards to active duty members being treated, I'm retired, and I need to remind folks that UCMJ strictly prohibits active duty members from participating in any kind of underground or any kind of ceremony work. There is a Religious Freedom Act, but the safest way for an active duty member to be treated is to find what is typically referred to as expanded access or compassionate use. And this year as well, there are going to be 10 different expanded access sites opening up, and the expanded access sites can enroll active duty members. In fact, at the clinic, the cancer clinic that I am conducting research, we were given a large amount of money by a philanthropist specifically to treat active duty members. Keep in mind that unlike stellate ganglion blocks that are $1,000, a complete course of MDMA assisted therapy for PTSD, which is what this expanded access trial is anywhere between $35,000 and $40,000. And that's largely because of the medicine itself is probably only a quarter of that. The majority of that expense is due to the fact that in the expanded access trial that the FDA has approved, 2 therapists are required, a male and a female. And there's, as Dr. Averill was saying, it's really not about the medicine. It's really about the assisted therapy that goes along with it. In fact, we can talk a little later about just the effect size of the medicine alone or combined with the therapy, which is dramatic. But the number of hours for those 2 therapists is about, there are 12 sessions, and 3 of those sessions are 8 hours long. So do the math, and it's almost 40 hours. So MDMA assisted therapy is expensive. And part of some of these research trials are looking at whether there can be one licensed therapist and another therapist that's either in training or a technician to help bring down the cost. But this is going to be expensive therapy. But so if those of you who know active duty members who may be appropriate, and I'll just say that for expanded access, even though the enrollment is much, I don't want to say easier, but it's more straightforward. Just a diagnosis of PTSD that has been attempted to that has had 2 previous either medicine or talk therapies that have failed, and that individual would be considered qualified. There's other restrictions, but basically it's a continuing diagnosis of PTSD for expanded access. And Dr. Averill and I can help direct individuals if they're interested.
Just really quickly also note, because I think the expanded access programs are a great option and certainly have sticker shock. if you look at some of the vetted retreats outside the country, which again, not without their challenges, especially for active duty military, those also tend to be, I mean, are at least a couple thousand usually, sometimes much more than that. But there again, from the thought of sort of safety and ethics, being very cautious about that. You know, if you're going to a retreat in Mexico and somebody's telling you it's going to cost you 30 grand, I would definitely take pause in that. And I would just note, relating to research and access also, somebody puts a really important question here about if there are conversations around return to shoot or return to operation for active duty folks. And I can tell you, yes, there are a lot of conversations around that. With, I think Dr. Kaufman has been included in a lot of those. There's the Reason for Hope group, the policy group has a couple of other military folks, retired and active duty, that are involved with it. But I think there's a lot of interest in doing research with active duty folks specifically for this reason, that, you know, these interventions generally work fairly quickly, and for many individuals may provide that opportunity to get them back into the field, get them back to work, rather than having to be medically discharged, and, you know, all of the challenges and various aspects and implications that come with that. I know one of the questions is whether or not there's any active duty research currently, and unfortunately my understanding is no. I think there's a lot of interest in that though, and I think that as special operators, that as a community, you have a bit more power than sometimes other groups of the military. So I would say, be loud about that. Be loud and obnoxious about that. Ask about that. Push for that. I think we are seeing a bit of a shift in the landscape, but I think absolutely this is something that the DoD should be very strongly considering and funding specifically. And certainly I would say, you know, I won't put words in Dr. Kaufman's mouth, but for myself, and I think many others, either veteran or active duty, there's interest, and certainly we would be happy to help support, consult, advise, engage, collaborate, whatever that may look like on those studies.
That's great. So we got a hands up from Dr. Lynch. Floor is yours, sir.
Yeah, hey, I saw a couple other participants ask questions. I saw Crystal's hand up there a second ago. I'd like to give some other people the floor. And then if possible, I could circle back on suicidality and or Ricky's question too. Over. Well, sorry, I didn't mean to put Crystal on the spot there. I thought.
Let you go ahead.
Oh, sorry. I'm sorry. Well, I wanted to just share just real quick my experience after, well, it kind of ties into a lot of the things that you guys have discussed. One is I was on active duty when I was referred to mental health for post-traumatic stress. And while I was there, I was told to be very honest about how I was feeling and what I was going through, and that it would not impact my career. However, after being honest and talking about how I was experiencing suicidal ideation, I lost my career. So, but fast forward to when I got my first SGB shot, it dramatically and significantly helped me with my suicidal ideation. I was able to actually have, I guess, more complete thoughts. I didn't have a lot of mind racing. I didn't have a lot of interrupted sleep. It completely took away my panic attacks that I was having in my sleep. And for me, that was a huge win because, you know, as anybody here can attest, it's like sleep is important. And so not having disruptions throughout the night was huge for me. But right now, as it stands, I just wanted to share one more thing is that, you know, I'm retired. I'm a retired E8, and I have been for years doing research on all of these things: ketamine, psilocybin, MDMA. I've applied to several clinical trials, and I've asked my VA here in Albuquerque, New Mexico several times if, I could get referred for any of these treatments. And the answer is always no. Matter of fact, my SGB treatment, I've had 2 of them, was paid for by a nonprofit because the VA, even though it's on their website saying that, they do offer it, I was told that it was not available for me. And I I recently asked for ketamine. I wanted to explore the ketamine option, and actually just received an email today from my primary doctor saying that there is a year wait list for that. So just as a veteran, I wanted to share that experience with you all. Thank you.
Can I jump in? Thanks, Crystal. I think that's helpful. I want to be clear about this just before we get off this topic. If there's anybody on the call, or anybody on this call who is in crisis, and you call my office tomorrow and say you need help, I'll get you in the next day, period. I don't care where you're flying in from. And I think this is really important. So in terms of, what can you do for suicidality? Do I have any evidence in the published medical literature that shows that stellate ganglion block decreases suicidal ideation or suicide rates? No, that's not out there. It isn't out there. And for a couple of reasons why. We usually look at people that are actively suicidal as excluded from studies. So this kind of turns into one of these questions very difficult to answer. Having said that, I dropped a link in the chat box from partners at Ohio State University, the Ohio State University Strive program, who Craig and Annabelle Bryant, who are former, somebody got that. Thanks, John, for laughing. They're a former Air Force psychologist. They're a wonderful team and experts in suicide prevention. Craig Bryant's just written a wonderful book as well, Rethinking Suicide. When it comes to suicide, we partnered up with the team at The Ohio State University, and we're in the middle of a randomized controlled trial to look at their program with cognitive processing therapy, or CPT, plus SGB. And everybody who gets into the trial gets both. It's just a question whether you get a stellate ganglion block as part of the study within the 2-week period of time, or you get it afterwards. And we're really just assessing what the effects of those are. Okay. Apart from the study, the particular organization at The Ohio State University has a great background in suicide. Okay. Break. As far as my experience over 10 years of doing stellate ganglion blocks, I have lost count, but I frequently get people who will send me a note after the block that says literally, "Thank you for saving my life." Not uncommonly, or something to that effect, like no drama here, like literally, "Thank you for saving my life because I was at the end of my rope." This is a hard thing to say without sounding overly dramatic or anything like that. And that's not my intent here. My intent is that I have a lot of and many years of anecdotal experience with people saying that, but not a shred of published evidence that I can cite. So this is, you go out on the thin ice here as a provider when you start making recommendations or claims like that. So I'm just going to caveat it and say that I don't have any hard evidence to say that, but I have, just last week got another note from someone off a random LinkedIn thing that said, "Hey doc, thanks a lot. I just want to let you know that you saved my life." And this is somebody I hadn't talked to in years. I treated him in like 2011 back at Fort Bragg. So both myself and Dr. Mulvaney, who we work together every day on this, we have a policy in our clinic. I mentioned before, we use a PCL5 for screening. When our front desk receives one from anywhere, it doesn't matter. I don't care if you're a veteran. I don't care who you are, how old you are. If you bust a threshold of 70s, if you're in the 70s, we consider that an in crisis, or in my experience, that's just a difficult thing to sustain. If your level of symptoms is that high, like that is very hard to keep on going. Like I don't need anybody to raise their hand and say, "Hello, I'm suicidal." I just look at that and go, that is bad. And then our policy is we pick up the phone and call them and say, "Can you get here tomorrow? I don't care where you're coming from. Can you fly here from California? We'll find a slot. We'll get you in the next morning. We'll get you at lunch, work after, whatever." Like my point is, this is a big deal, and I don't have a shred of evidence to hang my hat on that. But when somebody is in crisis, there are a lot of things that you can do. Lynette used the term earlier about a silver bullet or a magic wand. Stellate ganglion block is none of those things. It's not a magic wand. However, it is available. It's available right now. You don't have to enroll in a study or do anything that's tremendously costly. It stinks that it's not available in your hometown or at the VA or in every DoD hospital. I get it, it does, but it is available. And I'll tell you right now, like my door's open to you, Monday through Friday, whenever, and that's based upon both my experiences and my partner's experiences of treating people for years. I hope that helps, or I hope that helps someone. If it's someone who's in that position, or someone that's thinking about what can I do, end of the rope, please call.
That's really wonderful.
And Jim, if I could, I'd like to caveat on that just a little bit. One, first of all, thank you, Crystal, for sharing. Unfortunately, that's a very common story that we see, that you raise your hand for help, and because of that, you're punished from a career standpoint. In regards to suicidality, suicide is very complex, right? First of all, thankfully, the numbers are far, far too high, but it's still a low incidence thing. So it's very hard to study the effect of any intervention, whether it be psychedelics or SGB, on suicide. But as Jim said, a couple of things that I notice frequently. One, sleep restoration. So sleep restoration is going to help you think clearer. Two, cognitive improvement. So part of what we see in PTS is hypofunction or decreased function of your frontal cortex. And so if that's improved from the stellate, you think better and you make more rational thoughts. And then third, and I think foremost, what I see is that therapy, whatever type of trauma-based psychotherapy, it's difficult, it's uncomfortable, it produces panic attacks, it makes you feel lousy. And the stellate ganglion block helps those symptoms while you're engaged in those very tough psychotherapies, right? It also proves to you, listen, if I am willing to take a shot in the neck to help myself, it really opens you up to engage more with your therapist, engage more with your family. And you mentioned the families earlier, Lindsay. I'd like to talk to that just a little bit. And I know Jim's the same way. I can't tell you how many patients I've seen where I'll do a study on them and I won't see them for 6 months, a year. And then I'll get a call randomly like, hey, can I get another one? I'm like, yeah, why? Well, my wife tells me I need another one. Right? And so they don't even notice the change in their behavior, but those that we love around us start to notice the change in the behavior. And I see that repeatedly, where it just takes away that irritability, takes away that fight or flight, allows sleep restoration, and allows you to engage in the therapy that we know has long-term significant benefits in both suicidality and overall PTS symptoms. So anyway, that was my 2 cents.
Lindsay, I'm going to be the one that looks at the time really quick. I'm trying to look at the schedule, but if I may, there's a point that came from Ricky and a point that came from Justin and Crystal. Thank you so much. It is that bravery, which is going to extend, I think, to what is being asked. It is our stories. This is simple. All the docs in the room have said that there's no studies, but as military folks, when we hear another trusted warrior talk about it, then that's how we listen, right? Hey, don't jump out of the plane without ensuring your helmet's tied. Like all of these little things, or TTPs and SOPs, at the end, it is people talking about it and their experiences. If you hear it once and you hear it twice. I'll share that in 2019, I lost 2 operators to suicide. That was literally 1 month apart. And we were an organization that probably didn't have a suicide in 20 years. And I know the guy who committed suicide prior to me getting into the unit in 1999. And that was at the time that I was retiring and I was opening my Pandora's box, meaning after 23 years of special operations, to take care of my family, I had to endure opening that box so I can do my VA claim. I wasn't even thinking about getting better, right? Because I kept on just operating and that's what we did. And because of those guys committing suicide, one aspect of it, I asked for help. And help was the quick enrollment in getting an SGB, because we knew Sean Mulvaney. And there were other guys that came and girls that came from the unit that had gotten, and it had been life-saving, right? We had heard that. And that's all I needed to know, is the trusted warriors in the hallway had said it had saved their life, and that was registered. And so when I was at the darkest moment, and I've been around the world and in the deepest of combat, and that was the worst thing ever in my life, was to hear two guys that I could not stop them, their suicides, or even know that they were suicidal. So I asked for help. I got the SGB. And then when I went to NICO and therapy, I realized everything that I was missing. At the end, it is these stories combined with the medicine and trusted doctors that, I mean, you guys are passionate about helping us, right? I think this goes a long way. So hopefully we've been able to answer some questions, highlighted the importance. And I will say this, and this is what I had to tell my wife. I said, I don't care about my clearance. I've had a clearance for 25 years, but I already saw the impact, and I wish my two operator brothers would have gotten SGB, psychedelics, whatever had happened. And I reached the point that I didn't care about a job anymore. I just cared about living, and I care about taking care of my family and being an example to those I served with and those that I had trained. So I wanted to kind of throw that in there. Crystal, thank you for putting that on the table. That's what we do. And hopefully, because this is being recorded, that's the most impactful point. On that, I'd like to turn it back to Lindsay for some law and order in here. And then any other questions, please put them inside the comments.
Conversation is flowing really, really well. I mean, all of the questions that are coming in are the same topics that we had planned to talk about anyway. So I'm really enjoying the question and answer. One thing I would say, I know we talked a little bit about the role of the family, but do you have any specific tips for or recommendations or suggestions for significant others or battle partners, battle buddies, to help their SOF service member as they go through any of these interventions?
I don't know if this is to us. Okay. I think yes. I think there's some really critical points, and I think whether we're talking about psychedelic medicine or any other significant intervention or potentially significant experience, potentially transformative experience, that it is absolutely critical that be discussed with your family, whether that is your blood relatives or the family that you have chosen, the family that you have created, your special operator family, other community around you. Because I think, as I said, for many individuals who do engage in psychedelic medicine interventions, at least right now, the reality is that for many of those folks, that is the Hail Mary pass, that is the last ditch effort. And so choosing to engage in that has significant implications for you, the person doing it, for your partner, for your kids, for your broader family community around you. If it works and you have a very transformative experience, what does that mean for you? What does that mean for the family? If it does not work, what does that mean for you? What does that mean for the family? And I think, going back to that idea of expectations and other things, that it's really important that, especially for those who have a partner and kids, any of those things, I think when you're sharing a household with someone, those individuals experience so much of what you're going through in tandem with you, that however you go off and then come home is going to be incredibly impactful for them. And I think a really important note, Dr. Kaufman and I actually had the opportunity to present at a conference together in November. And there was a woman there, Allison Wilson. Some of you may or may not know her. She is the wife of a special operator, now a veteran special operator. But he had an experience, a very transformative, positive experience with psychedelic medicine, and very much was that Hail Mary pass. This is the last option for him. Had a very overwhelmingly positive experience. And when he came home, she was, I'll try to relay the story as best I can. I think incredibly delighted, relieved, overwhelmed with joy that something seems to have saved her husband and the father of her children. And also really struggled with a bit of resentment and a bit of confusion and a bit of all sorts of mixed emotions, because generally, though I think there is not nearly enough support for our active duty or our veteran community, there is so much more support for the service member or a veteran themselves than there is for the husbands, the wives, the kids. And so her husband went off and had this experience, went to Mexico, did this thing, and came home, and she was still there dealing with all the same things. And so I think just really approaching the planning with intention as a family, the planning with an understanding of how significant it may be, with an understanding that for people who do respond very well to these interventions, you may be coming home seemingly an entirely different person than you were when you left, which again is really lovely and exciting in many cases, and also kind of abrupt and startling for the family who you saw 3 days ago as the person that were changed by the trauma, by the stress, the multiple deployments, all of these things. So I think the thing that I would say, just as the ultimate sort of baseline take home, is engage with your family, be open, honest, let yourself be vulnerable, of course, with the people that you can trust. Unfortunately, sometimes families are not as supportive as one might hope. So being, again, thoughtful about that, but engaging those individuals who are in your circle, who are the people that you trust and can rely on for support, both to prepare and plan before you go, but also to think about preparing and planning for when you come home. Because often, again, no matter the outcome, there may be lifestyle changes. There may be, whether that's things like shifts in diet, exercise, mindfulness, balance of, work, family, hobbies, whatever. Your whole family, again, is going to be impacted by that, and going to be experiencing those things in tandem. So just being very thoughtful about all of that, I think. Bob, other things you would say?
Thank you for bringing that up, Net. It's really unfortunate that there's that the wounds of war are identified in a single individual as opposed to a system. And you just pointed out the prudence of managing, of healing a family as opposed to a wounded warrior. Part of that support really comes in. The question was starting out with your primary care provider. And I can tell you that facilities are really limited, but your primary care provider's knowledge and awareness of what's out there and what's available shouldn't be limited to what he or she has in their particular MTF or clinic. There are a lot of treatments that tonight we're focusing on the two that appear, well, one that appears very sort of mysterious, and that's psychedelic, and another that not just appears but is incredibly therapeutic and clinical. But we went through a similar discussion a while back with hyperbaric oxygen, and there's still studies that indicate that there may be reason to be excited about hyperbaric oxygen therapy. Similarly, transcranial magnetic stimulation and the offshoot of it, MERT, magnetic transcranial stimulation. These are, your provider really should be aware of these emerging treatments, and have a conversation with him or her in terms of what they know, what they don't know, what they think, because it's only going to ultimately help you more to have that kind of a constructive dialogue as far as individualizing your care. I guess that's my point, is that You know, I've spent the last dozen years at NICO, and what NICO does is NICO individualizes care. There's a tremendous liberating empowerment in terms of you being able to sort of being given options and say, you know what, this makes the most sense for me right now. And if this doesn't work, I'm going to try that, as opposed to a very passive sort of outstretched hand, like a mendicant, you know, like somebody on the street, you know, clutching some change. You know, we really need to we need to really empower service members and veterans through education, and your primary care provider should be one-stop shop for that. Over.
Dr. Lynch, did you have something that you wanted to mention?
Well, I'll just say spending 20 years as a primary care provider, being a physician in a deployable unit in SOF for my entire career. I took care of SOF families my whole career, and I think it's really important to highlight this. There are many times, many of us within our organizations, within our community, they can do a really good job of sustaining their performance at work, sustaining their performance among their teammates, only to completely come unglued when they walk through the home of their door. And the emotional trauma that's been wreaked on you know, hundreds of thousands of families from PTSD, you know, through secondary effects on the family is tremendous. And I just hate to have that go unsaid in this forum, particularly with the name of this organization. In my experience, there's a component of that I speak to all of my patients about, and that is this: there's a tremendous amount of guilt and shame that comes from PTSD that's rooted in the fact that people, whether it's a man or a woman, who responds lashes out at family, is irritable at kids, whatever in the home, will behave a way that they're later ashamed or embarrassed for, because the way I look at things through this lens, the sympathetic nervous system is frankly broken. It's dysfunctional. It's stopped working. And to me, what I think a lot of my patients over the years have appreciated is that, like, nobody makes you feel bad. You're not ashamed because your thyroid stops working, right? Like nobody feels bad about that. Nobody feels bad if you break your leg and your buddy goes, "Hey, let's go for a run," and you're like, "Oh, I can't, my leg's broken," right? Like that's not a thing. So, but people will respond in a way that is uncharacteristic for them, whether it's flying off the handle or losing their temper at their kid. It's got to be one of the most common things that I've heard over 20 years is, you know, going 0 to 60 on your kid for spilling the milk or something like that, or lashing out at your wife for no good reason, feeling a tremendous amount of remorse and shame and guilt over that, for something that you physically cannot control. Now, to a person who I speak to after their stellate ganglion block, when their symptoms have been reduced, they know this in their mind, and no one's really told them this, you know, that give yourself a break. You can't help the fact that your sympathetic nervous system has been dialed way the hell up and it's not resetting itself. Like, you're stuck. And as a result of that, you know, the impact that I've seen on the families is tremendous. Now, that's not the question that was asked. You know, I get it. And I think it's fair for us to say, you know, families should be involved in the healing process. I got it. And in fact, whenever I can, I love to have spouse. I have a lot of moms come into the clinic room with me when I perform SGBs on their either teenagers or adult children. I think it's a very important part of the healing process. And in my experience, you know, I don't know how many people have told me afterwards, "Thank you for giving me my husband back. Thank you for giving me my son back." A gentleman just called me from Charlotte last week who happens to be a psychologist. He said, "Doc, thank you for giving me my son back. I haven't seen my son in 15 years after the trauma. Now he's back." So I think that these things are not, they're so ingrained in the family fabric, but I think the family has to be part of everything that we do with the treatment, and I think has to understand this kind of lack of control that many people have had on their actions until we could actually help, you know, tip the autonomic nervous system back into something that can be controlled, that's a real source of friction in families. I hope that makes sense. I rambled a bit there, but that's the point I was trying.
No, Dr. Leach, I think that was excellent. And I just chatted with Lindsay to make sure that I can interrupt one more time. And I think we're going to then hand it to her based on time. And then however they want to wrap it up, excuse me. So I think one thing that is key, and I know the providers, the board here knows is, but I'll tell you from my experience, and guys, that I'm about a year and a half post-retirement, and again, 23 years in special operations, is I just returned home. All right, let me say that again. I just returned to my family. So for 20 years at the command that I was in, I wasn't home. I wasn't part of the family. My family was in the team room. And so it took me now to realize that when I came home only to eat, sleep, juggle life bills. And my priority, unfortunately, selfishly, was to operate one more day. That's my life. That's a SOF operator's life. That's probably a Marines, a SEAL, an Air Force, whatever you are in the military. Most folks, you have a purpose, and that purpose is serve this country to the highest capacity. And for some, it becomes our identity. And so what I've realized now in how I help others into family members of those that I love, folks that I've served with, is having to get to the family and explain. For some of us, then they realize it. I wasn't home for 20 years. I wasn't part of the family. My family was in the team room. And just now am I realizing that I'm reintegrating back into my house. So hopefully that kind of lends some perspective on where our minds were. Again, I slept in this bed, but I wasn't here. I was ready for the next time to go out. And that's where my mind was. So I didn't have these outlashes. We didn't, have these issues in the team room. I had them at home. So hopefully that helps folks. And with that, Lindsay, I think I've covered a lot of the pertinent questions, and the board has done an amazing job at, I guess, looking at my notes because they've answered everything. So I'll hand that back to you.
Yeah, it's amazing how we really, it makes us feel good that we knew what people wanted to hear about. So we were able to touch on a lot of those topics. But then we've also had some really surprising stories and questions as well. So I want to thank everybody who has been here tonight. And just to let you know, before I hand it over to Kaylee for the closing comments, that I put 2 links in the chat, and we'll also send those out via email to you. One is to our resource page, which has the resources that were provided prior to the event, but we'll go ahead and add everything that we've talked about here tonight, as well as some contact info for the presenters. And then also a link to a survey where you can give us quick feedback. I swear it's only a few questions on how you found the event. And then also you can ask any further questions that you might have as well. So now I will turn it back over to Kaylee for our closing comments.
Hey, everybody. I hope you found tonight interesting and enlightening, and had some good questions answered. Thank you for being part of our first deep dive event. Dr. Lynch, Dr. Titi, Dr. Averill, and Dr. Kaufman, thank you so much for your time, your expertise, your dedication, especially to the special operations community. If you attended tonight and you still have questions, or they come to you later tonight, tomorrow, and you'd like to ask the doctors here, please refer to the link in the chat, or simply email our team at home@msofc.org. We will make sure to get the questions answered and either include them in resources or respond directly to you and get your questions answered. Also, keep an eye out for the resources that will be following up from the event, many that came up in the chat, or that our experts will provide following the event if they have any reflections from the conversation and questions. We will be following this up with extra pages on our website and our blog. You can, if you're not already, you can follow us on LinkedIn or Facebook, where we try to make sure we push out everything that's new on the website and for families. The link, there's also a link in the box that has a few survey questions about tonight. We'd love your feedback about what you enjoyed and how we can improve these deep dive events. We'll have one a quarter following the SOF team room. And much of the planning that goes into these events is due to what we hear from you in between. So never hesitate to reach out. As a public health initiative, we do seek to get the answers, bring the evidence, and put it out to the community in the best, most effective way we can. Please mark your calendars for our next SOF team room, which is May 11th. Lieutenant General Slife, the Commanding General of Air Force Special Operations, will be our keynote speaker. The SOF team room will take on hard topics tied to transition from service. And it will also, in our health sprint, will cover operator syndrome, also recognized as the natural consequences of an extraordinarily high allostatic load or chronic stress. The next health deep dive will follow that team room in June, and it'll cover that critical topic that is so much reverberating through our community. There's not a lot out there, and we're doing our best to put out legitimate, balanced health information so our families know where to turn, or at least what questions to ask and where to go. Just want to remind you, please, if you have any questions about transition or tonight, please connect with us and we'll make sure that the events respond to exactly what you're looking to hear. So thank you all for tuning in. We appreciate everything. And we hope you have a good night.